intramuscular tube forming the food passages between the pharynx and the stomach. It is extending from the lower part of the neck to the upper part of the abdomen. The esophagus is about 25 cm long, flattened anterior-posteriorly, and the lumen is kept collapsed. It dilates only during the passage of the food bolus. The pharyngo-esophageal junction is the narrowest part of the alimentary canal except for the vermiform appendix, right? The esophagus begins in the neck and the lower border of the cricoid cartilage, where it is continuous with the lower end of the pharynx, descends in front of the vertebral column through the superior and the posterior part of the mediastinum, and then pierces the diaphragm at the level of the 10th thoracic vertebra. This is the part of the diaphragm. It ends by opening into the stomach at its cardiac end and at the level of the 11th thoracic vertebra. Curvatures. In general, the esophagus is vertical but shows slight curvatures in the following direction. There are two side-to-side curvatures, both towards the left. One at the root of the neck and the other one at the lower end. It also has an anterior-posterior curvature that corresponds to the curvatures of the cervicothoracic spine. Normally, the esophagus shows four constrictions. They are seen as indentations at the beginning, 15 centimeter or 6 inch from the incisor teeth, crossed by the cricopharyngeus muscle over here. Then second, when it crosses the aortic arch, that is about 9 inch from the incisor teeth. Then it crosses the left bronchus, that's about 11 inch from the incisor teeth. Where it pierces the diaphragm, it is about 15 inch from the incisor teeth. The distance from the incisor teeth are important in passing instruments like the endoscope into the esophagus. For the sake of convenience, the relations of the esophagus can be studied in three parts: the cervical, the thoracic, and the abdominal. Relations of the thoracic part of the esophagus. Anteriorly, we have the trachea, the right pulmonary artery, the left bronchus, the pericardium with the left atrium, and the diaphragm. Then to the right, we have the right lung and the pleura, the azygous vein, and the right valgus. Posteriorly, we have the vertebral column, the right posterior intercostal arteries, the thoracic duct, azygous vein with the terminal parts of the hemiazygous veins, thoracic aorta, the right pleural recess, and the diaphragm. To the left, we have the aortic arch, left subclavian, the thoracic duct, left lung and pleura, left recurrent laryngeal nerve, all in the superior mediastinum. Whereas in the posterior mediastinum, we have the descending thoracic aorta, the left lung and the mediastinal pleura to the left of the esophagus. Arterial supply. Now here we have the cervical part of the esophagus up to the arch of aorta, supplied by, we can see, the inferior thyroid artery. The thoracic part supplied by the esophageal branches of the descending aorta, and then the abdominal part is supplied by the esophageal branch of the left gastric artery. Venous drainage. Blood from the upper part of the esophagus drains into the brachiocephalic veins. From the middle part, drains into the azygous vein, and from the lower end, it goes to the left gastric vein and vena azygis via the hemiazygous vein. The lower end of the esophagus is one of the sites of portosystemic anastomosis. Important. The lymphatic drainage. The cervical part drains into the deep cervical nodes, thoracic part into the posterior mediastinal nodes, and the abdominal part into the left gastric nodes. Nerve supply. The parasympathetic nerves, upper half of the esophagus, supplied by the recurrent laryngeal nerve, the lower part by the esophageal plexus formed by the two vagi you can see over here. The parasympathetic nerves are sensory, motor and secretomotor to the esophagus. Sympathetic nerves, upper half of the esophagus, fibers are coming from the middle cervical ganglion and run with inferior thyroid arteries. Lower part, fibers are coming directly from upper four thoracic ganglia to form the esophageal plexus before supplying the esophagus. The sympathetic nerves are vasomotor. Esophageal plexus is basically formed by the vagi, but sympathetic fibers are also present. Towards the lower end of the esophagus, the vagal fibers form the anterior and posterior gastric nerves, which enter into the abdomen through the esophageal opening of the diaphragm. Now, in portal hypertension, communication between the portal and the systemic system draining the lower end of the esophagus dilate. The dilatations are called the esophageal varices. Rupture of these varices can cause severe hematemesis or vomiting of blood. Now, the esophageal varices can be visualized by barium swallow and they appear to be worm-like. Left atrial shadow, as in mitral enlargement due to mitral stenosis, can also be visualized on the barium swallow, which is the barium swallow, showing the esophagus. The enlarged atrium causes a shallow depression in front of the esophagus. The barium swallow also is helpful in diagnosis of esophageal strictures, carcinoma, and achalasia cardia. Normal indentations should be kept in mind while performing esophagoscopy. The lower end of the esophagus is normally kept closed. It opens only by stimulation by the food bolus. In case of neuromuscular incoordination, the lower end of the esophagus fails to dilate with the arrival of food, thus causing accumulation in the esophagus. This condition of neuromuscular coordination is characterized by inability of the esophagus to dilate and is known as achalasia cardia due to maniacal absence of nerve cells in the wall of the esophagus. Improper separation of the trachea from esophagus during development gives rise to the tracheoesophageal fistula over here. You can see over here, and compression of the esophagus in cases of mediastinal syndrome cause dysphagia and difficulty in swallowing.